Today I want to touch on this issue that, is present, I think, broader in society, this kind of notion that, we have insomnia is obviously one of the most common sleep disorders out there, but there's some concern about long-term treatment with medications and just kind of exploring this notion of what's worse, the disease or the treatment for brain health. So here are my learning objectives. I'm going to break this talk down into three parts. First, we're going to understand the impact of insomnia on brain health. Then we're going to pivot to the impact of insomnia treatments and really focused on medicinal treatments on brain health. And then spend the last third talking about a novel method I've been involved with developing that we're excited about to assess brain health. And so, as I mentioned, really this talk boils down to this very simple concept. What's worse for your brain? Not being able to sleep or taking a medication to allow you to sleep? And, it might seem like maybe for some of you it's a simple answer, but for others, maybe not. So let's explore this a bit. And so as we get into this, I think it's really helpful to understand the way people think about it. So this was a Harris poll done in 2021 called the Wake Up America Survey. And it surveyed 1,000 individuals or people with trouble sleeping. That's what PWTS here is on the figure. These are people that have been diagnosed with insomnia by a physician at some point in their lives. And the survey also assessed the thoughts of 300 primary care doctors and 152 psychiatrists. And this question here was essentially, how often do you, for a person with trouble sleeping and a patient with insomnia, how often do you bring up this difficulty, these problems you're having with your primary care doctor? And you can see 31% say never, and 16% during less than half of visits. So almost half of the people barely discuss their medical problem with their doctor. And when they're asked why, they say that they are fearful that the doctors will prescribe a sleeping pill. So if we explore this further, what's going on here, a little over half of PCPs and 45% of psychiatrists will only prescribe prescription sleep medication after they exhaust all other approaches. Yet, you have 3/4 of PCPs and 4 out of 5 psychiatrists think prescription sleep medications are more effective than over-the-counter or natural sleep aids. And that's what these other approaches are, is kind of these, lifestyle changes, over-the-counter and natural sleep aids. So that's a bit strange. I mean, that they think it's most effective, but they won't reach for it first. They also, the majority, 70% of PCPs, 67% of psychiatrists feel that short-term use of medications to treat insomnia is only acceptable, and that natural sleep aids are the only long-term safe treatment. Again, about half making that claim. And then more PCPs never prescribe prescription sleep medication than those that use them first line. Exploring this again a little further, despite everything that I just told you, and the people with insomnia and their perception of these treatments, 70% are desperate to find a solution that helps them get quality sleep and fully function the next day. Yet about half have never used a prescription sleep medication to help with trouble sleeping or insomnia. So there's a big disconnect. People are desperate for solutions, but they don't want to use the best solution ostensibly that's at their fingertips. And then at the bottom here, this is just another disconnect between the patient with trouble sleeping views on their satisfaction with their treatment compared to their healthcare provider perception of that. And so this indicates that the healthcare providers have a rosier view of the insomnia patient's satisfaction with treatment options than the insomnia patients have themselves. And also here, there's this stigma around treatment. So 2/3 of people feel that taking a prescription sleep medication is a stigma. And, that's really peculiar to me. A stigma is a mark of disgrace associated with a particular circumstance. And, I don't know that all diseases have stigmas. Why does insomnia have one? I mean, maybe people feel we spend 1/3 of our life sleeping, and so it's somehow a personal failing if you're unable to do it. But regardless, this stigma does exist. So this is the kind of bizarre current state of affairs. Insomnia patients don't discuss their insomnia oftentimes with primary care because they don't want to get prescribed a sleeping pill. That said, they're desperate to find a solution that helps them get quality sleep and fully function the next day. Doctors, on their part, acknowledge that prescription medications are better than OTC or natural remedies, but they'll exhaust all other avenues, all less effective avenues first before prescribing an insomnia medication. And, then the majority of patients think there's a stigma to taking a sleep pill. So how the heck did we get in this strange situation with the treatment of this disease? Well, I want to talk a little bit about this Medicare Advantage poll done in 2021 that surveyed over 1,200 people aged 18 and older to explore this notion a bit further, kind of setting up my talk further here. So in this survey, these are the percentage of respondents who are somewhat or very fearful of the following. And you can see Alzheimer's disease was number 2 on the list, right behind cancer. And ahead of heart disease, stroke, and COVID-19, which this survey was done in 2021, as I mentioned. Despite that, the deaths from Alzheimer's disease were much less than cancer, heart disease, even stroke. So the death risk doesn't seem to perhaps drive this fear. But if they're asked, how fearful are you of the following occurring as a result of a serious disease or injury, cognitive decline is number 1. So, people thought that was a bigger fear than losing physical mobility or being put in a long-term nursing care facility or being unable to afford treatment. All these other things were raising less fear than cognitive decline. And then lastly here, you say, what would be worse, to have the disease or care for somebody with the disease? And of these diseases here, Alzheimer's disease was the only one where people felt that caring for a loved one with it would be worse than actually having it themselves. So this sets things up, which is my talk is going to focus on this kind of notion that there's a fear that insomnia medications somehow cause dementing illness. And this is why patients don't want to talk about their insomnia. They don't want to get prescribed medications for it. There's a real concern around that. And I know I see that in my practice, and I get asked this question not infrequently. We got to appreciate this notion of emerging bidirectionality between sleep impairment and Alzheimer's disease. Of course, the neurodegeneration of Alzheimer's disease can affect the monoaminergic centers and GABAergic centers in the brainstem that control sleep and wake. These areas are also in the dorsolateral hypothalamus. All of these areas can be impacted negatively by the pathophysiology of the disease, which can cause disruption not only of circadian rhythms, but also sleep in general. In fact, the ventrolateral preoptic nucleus is crucial to sleep onset, and certainly this can be impacted negatively in Alzheimer's. So we understand that people with Alzheimer's have impaired sleep. The more recent understanding, and that we're going to talk about here today, is how impaired sleep itself might be contributing to Alzheimer's disease. So first here, we're going to talk about some of the epidemiology and other data that shows an association between poor sleep, just poor sleep, and dementia. So these are a number of systematic reviews and meta-analyses. You see the forest plot on the bottom involving 5 studies looking at a relationship between physician-diagnosed insomnia and risk of incident all-cause dementia. and you can see that there was a 53% increased risk of all-cause dementia in those with insomnia. And this was present even when controlling for the potential confounding effect of benzodiazepines. The second study here, which showed insomnia increased the risk of cognitive disorders by 27%, also adjusted for the presence of medication. So these findings are present whether or not somebody's taking the medication. If they have sleep disturbance, there's this association with dementia and cognitive problems. And you can see further there just additional studies supporting this. And the last bullet item there, this study showed that insomnia increased the risk of Alzheimer's disease, but did not confer significantly higher risk for other types of dementia, which is perhaps interesting to wonder if there's a different relationship or a unique relationship between sleep and Alzheimer's as opposed to some other causes of dementia. This was a Swedish study here looking at disturbed sleep pattern and incident dementia. So these are 214 adults, 75 and older. They did not have dementia at baseline and were followed up first 3 years later. 40% of participants reported reduced sleep depth and duration at baseline, and following them between the 6th and 9th year after baseline, you can see here that there was a 28.5% of individuals were diagnosed with dementia, and 22% had Alzheimer's disease. The light in my office just went off because I guess I'm not moving enough. There we go. Yeah, so here, if you look at the cumulative hazard on the y-axis and time in days on the x-axis, you can see kind of a dose-response relationship that you would expect to see where, the risk, the cumulative hazard is highest in those with more moderate to severe sleep reduction. That was more than those with mild sleep reduction, which was more than those with no sleep reduction. So reduced sleep depth and duration was associated with a 75% increase all-cause dementia risk and double the risk of Alzheimer's disease. And again, there was no evidence supporting a moderating effect of the use of sleeping pills. So, I guess there's lots of ways you can interpret that, but, one other way would be maybe the sleeping pills don't prevent this from happening. We'll talk more about whether or not they cause it, but this would suggest maybe they don't prevent it. Let's pivot away from epidemiology and look at some neuroimaging data here. So this was a study that involved the Wisconsin Registry for Alzheimer's Disease Prevention. So these were 98 individuals who had a family history of Alzheimer's disease, but were cognitively normal at the time of this study. And they had PET scans, and you can see on the y-axis, that's the mean Pittsburgh compound B distribution volume ratio, with higher values indicating more amyloid burden. And then on the left, you have what's called sleep adequacy, in the middle, somnolence, and on the right, sleep problems index. So sleep adequacy is just, do you get the sleep that you need? Do you get enough sleep to feel rested? Somnolence was, do you feel sleepy during the day? Do you have trouble staying awake? And do you nap during the day? And sleep problems index was a combination of factors. Do you feel rested when you wake up? Do you awaken short of breath, which can be an indicator of sleep apnea? Do you have trouble staying asleep? Do you have trouble staying awake? And do you get the amount of sleep that you need? And so here, a lower sleep adequacy is worse. And then higher somnolence is worse, and higher sleep problems index is worse. And so you can see in all instances the amount of amyloid observed on PET scans in typical areas that are susceptible to this, such as the angular gyrus, the frontal medial orbital complex, the cingulate gyrus, and the precuneus, did show more amyloid burden in those that had problems with sleep. That was on neuroimaging. If we look at the cerebrospinal fluid here, also in the Wisconsin Registry for Alzheimer's Disease Prevention folks, this is a slightly higher sample size than the previous study. These folks were 40 to 65 years of age and were cognitively normal, and they had their CSF sampled for AD biomarkers. And the sleep adequacy is the same as I just mentioned. The medical outcome study sleep scale was what they filled out. But again, it's just, do you get enough sleep to feel rested when you awaken? And do you get the amount of sleep that you need? Here we're looking at beta amyloid plotted as a function of AB40 to normalize it based on individual differences in the amount of beta amyloid a person produces. Lower values on the y-axis are worse, and so you can see as sleep adequacy goes down, there's a more amyloid burden in this particular figure. And then if we look at the sleep problems index, again, kind of at a sleep apnea question, some insomnia questions, some sleepiness questions, do you get the sleep that you need? If you look at the left, we have the total tau. In the middle, we have phosphorylated tau, and on the right, we have YKL40, or also known as chitinase-like protein, which is a measure of inflammation in the brain, which is often associated with Alzheimer's disease. And you can see in each instance here, there was, they did observe more of each of these substances in the cerebral spinal fluid in those people that had more sleep disturbance. Let's talk a little bit about proteostasis, because I think that this is important as well. When proteostasis is basically the biogenesis, folding, trafficking, and degradation of proteins that happens in our bodies all the time throughout the course of the day and night. And when we have healthy proteostasis on the left, we all make a misfolded protein here and there, but we have the ability to refold that protein. If we can't do that, we can degrade it, and we can keep our extracellular environment clean. When sleep becomes impaired, either there's not enough of it, or you can't sleep, or you have sleep apnea or another sleep problem, you get more misfolded proteins. The refolding and degradation mechanisms don't work as well, and so the extracellular environment begins to accumulate these proteins, such as beta amyloid, which can be problematic. Now, the longer we stay awake, we trigger something called the unfolded protein response in our bodies, which helps us clean things up to the best of our ability. But as we get older, we know in mice that are older, this unfolded protein response doesn't come on as robustly as it does in younger mice. And so there may be something related to aging that also interferes with our ability to clear out these proteins from our brain. And no talk about this would be complete without mentioning the glymphatic system that you're all certainly familiar with. This gets turned on typically when we're asleep, typically in deep non-REM sleep or N3 sleep. The brain contracts a little bit, and it opens up these perivascular channels that you can see on the right, which allows a removal of proteins and solutes out of the brain. So at the top, in a young individual, you can see the periarterial space. CSF is coming in. The little blue squares are aquaporin 4 channels, which allow the solutes to be flushed across the extracellular space and to the perivascular channels in the venous side and clear out beta amyloid and other metabolic waste. As we age, some of these aquaporin 4 receptors become depolarized into the parenchyma. The system doesn't work as well as it did when we're younger, but it still works pretty well. And then as we get, as some people begin to develop Alzheimer's disease, beta amyloid can clog up these perivascular channels. The astrocytes don't work as well. There's more aquaporin 4 depolarization, and you get accumulation of beta amyloid and Alzheimer's disease. And certainly inflammation and the relationship between poor sleep and inflammation is an important component here as well. So let's say, again, you have insomnia, or your sleep is disturbed from sleep apnea or restless legs or some other reason, or you're sleep depriving yourself. You're going to generate systemic inflammation in your body, and that's going to include pro-inflammatory cytokines and C-reactive protein, which then influence microglial cells in the brain to become primed. and they become amoeboid and they don't work as well. So these primed microglial cells don't clear out proteins like beta amyloid very well, causing more accumulation. And they also contribute to more localized inflammation. They begin to express IL-2 and IL-23, which is not typically expressed in the brain. And then this results in astrocytes expressing receptors for these interleukins. And then that in turn causes increased deposition of amyloid and further neuronal damage. So just pointing out that the systemic inflammation from impaired sleep is a factor here as well. And then, if we try to bring it all together in a more simplified figure, that would be this slide here. We have multiple causes for disturbed sleep shown: sleep disordered breathing, sleep apnea, sleep fragmentation for any cause, insomnia, and then chronic insufficient sleep or sleep deprivation. These things are going to reduce slow wave sleep, which is also called N3 sleep, which is going to increase neuronal excitability and increase beta amyloid production. And then you have reduced slow wave sleep, reducing lymphatic functioning, which reduces clearance of tau and beta amyloid. Sleep disordered breathing also causes chronic intermittent hypoxia, which is pro-inflammatory and causes oxidative stress, which also contributes to the pathophysiology here. Certainly, sleep disordered breathing is also associated with cerebrovascular disease and can result in vascular dementia. So that's the first third here, just kind of talking about all the different ways that sleep disturbance itself can contribute to dementing illness. So let's pivot here now and consider the association between insomnia medications and dementing illness. So we'll start here with this forest plot and of 8 studies looking at benzodiazepine use and dementia risk. And you can see that there is a 78% greater odds of developing dementia if you've been exposed to benzodiazepines in this study anyway. 3 of these studies did look at insomnia being present as well as benzos and continued to show an increased odds ratio. Now, in this study as well, they looked at other medications, and interestingly, statins were also associated with an increased dementia risk. And you have to wonder why that would be. Nobody thinks that statins cause dementia. Certainly, you might imagine people at risk for vascular disease would get statins. Maybe the statins don't treat it completely, and they go on to develop a vascular dementia. People typically wouldn't think the statin caused that. So that's just a brief thought, and we'll circle back to that later when we consider insomnia medications. So we're going to go through some specific studies here. This is a study in France, nearly 7,000 participants, 65 and older. They had a structured interview to talk about sleep complaints, sleepiness, insomnia, sleep quality, and medications at baseline. They followed these folks over 12 years and found that persistent use of hypnotics, benzodiazepines, or Z drugs, Zaloplan, Isopiclone, and Zolpidem, increased risk for Alzheimer's with a hazard ratio of 1.28. But these results were not adjusted for the presence of insomnia or other sleep disorders, which raises the question about what's actually causing this association. We further explore benzodiazepine use, and most of the studies have looked at benzodiazepines and not other, insomnia medications per se. Many of them do include the Z drugs as well, but just kind of letting you know what the data is. This was a study in Quebec in Canada, 1,700 folks with AD and 7,000 age and sex-matched controls. They looked for dispensation claims for benzodiazepines 5 years before the diagnosis of Alzheimer's. And that 5-year lag is important because you don't want the relationship between the medication and the dementing illness to be due to somebody expressing, early mild cognitive impairment and getting the medication because actually they're expressing the early stages of the dementing illness and not and not for the insomnia before that. So having a lag period there is important. But they found that an increased risk of Alzheimer's disease with adjusted odds ratio of 1.51. And there was no association found for a cumulative dose less than 91 prescribed daily doses, but as the dosages went up, the association was seen. Another benzo study here, a case control study with over 1,400 incident AD Alzheimer's disease cases and 1,400 age and sex match controls. The mean age was 86. Cases were identified by filling prescriptions for medications typically prescribed for Alzheimer's disease, acetylcholinesterase inhibitors and N-methyl-D-aspartate receptor antagonists. Benzodiazepine exposure also included the Z drugs. And initially, they found that there was, benzodiazepine used prior to the first prescription of an AD-specific drug was similar in cases and controls. So that's interesting. The induction period was 2 years, so the last study was 5. This one's 2. But they found benzodiazepine use was not associated with an increased risk of developing Alzheimer's disease. And long-term benzo use, greater than 30 prescriptions, yielded an adjusted odds ratio of 0.78. So, no difference in relative risk of AD between users of benzos or Z drugs. And then this study here was actually done at Group Health in Seattle a number of years back, was looking at, it's a prospective population-based cohort study, over 3,000 individuals, 65 years of age and older. And they had 2 enrollments, one in the late 90s, another one in the early 2000s, and then they've had rolling enrollment going forward after that. Every 2 years, they assess people with a cognitive abilities screening instrument in order to see if there's some cognitive impairment. And if there was, these individuals went to see physicians who could make correct diagnosis of Alzheimer's. And what you see here is quite interesting, for me anyway, that you can see as the doses of benzodiazepines go up, the total dose exposure goes up, the hazard ratio goes down. And this is shown quite well here on the right in this figure, where you have the hazard ratio on the y-axis and cumulative total standardized daily dose of benzodiazepine on the x-axis, where you can see there appears to be some relationship early on, and then there's a negative relationship. And so ultimately, these researchers concluded that there was no relationship between benzodiazepine exposure and use and Alzheimer's disease risk. This another study looked at hypnotics and incident dementia and Alzheimer's disease. So it was a longitudinal study and meta-analysis of 1,500 older adults, mean age 73, 45% female. They were followed for 4 years. They looked at ever use of hypnotics was associated with an increased risk of Alzheimer's disease with a hazard ratio of 1.96. They then did a meta-analysis in nearly 4 million participants and revealed a correlation between the use of hypnotics and the risk of dementia with a 23% increased risk. But according to subgroup analysis, neither association was significant among subjects with a history of insomnia. So Dr. Kawada wrote a letter to the editor related to this study, and I put it in here because it's pretty weak, I suppose. But they say, I suppose that sleep medications present relatively smaller contribution for dementia development among major dementia risk factors in older subjects. So that's quite a bit of equivocating. And if, the final study to look at here is this association of benzodiazepine, Z drugs, and other anxiolytics with dementia, subsequent dementia in patients with affective disorders, because there is some thought that depression in particular can be an effect modifier if there is a relationship here. So this was a cohort and nested case control study of 235,000 patients, 171,000 with any use of benzodiazepine or Z drugs. They followed them for 6 years, 4% diagnosed with dementia, and any use of benzodiazepine or Z drugs showed no association with dementia. And in the cohort analysis, the number of prescriptions and the accumulated dose of benzodiazepines or Z drugs were not associated with dementia. And in fact, in the case control study, subjects with the highest use had the lowest odds of developing dementia. So this might suggest that actually there's an opportunity to treat sleep problems and that maybe that it could prevent dementia. That hasn't been established, but I think it's an interesting thought to think about, and we'll get back to that in a minute here. But one of the other issues that's important is what kind of mechanism would we imagine that would associate these medications with dementia development? And there's no real good neurobiologic rationale for why GABA agonism might result in the development or worsening of AD. In rats, on diazepam, they lose inhibitory synapses downstream of GABA receptors. So this does suggest that the medication itself can change neurobiology a bit. Benzos can also, chronic use can reduce benzodiazepine receptor density, and there may be implications to that. Perhaps some other thinking is that the benzodiazepines impact sleep architecture in ways that are unfavorable, particularly reducing slow wave sleep or N3 sleep, which we know is the sleep stage where the lymphatic system opens up, and it's crucial to clearing protein out of the brain. So I mentioned this notion of, let's turn this around. I mean, if we treat insomnia, can we bend the curve of dementia development? And this is a really interesting study of suvorexant. So in sleep medicine now, we have medications called dual orexin receptor antagonists. Orexin is a neuropeptide in the brain, in the dorsolateral hypothalamus, that's deficient in people with a disease called narcolepsy that I've spoken to you all about in the past. And pharmaceutical companies use that understanding of the neurobiology of narcolepsy to say, hey, if we antagonize this system, then we can reduce wakefulness and potentially treat insomnia. So we have three DORAs, dual orexin receptor antagonist medications. Suvorexant here is also called Belsomra. We have Dayvigo, which is lemborexant, and we have Quviviq, which is Daritorexant. So anyway, suvorexant was administered either at 10 milligrams or 20 milligrams, or placebo was given to 38 cognitively unimpaired folks aged 45 to 65. And then they had an indwelling catheter and had cerebrospinal fluid removed every 2 hours for 36 hours. And what they found was the ratio of phosphorylated tau to unphosphorylated tau was decreased about 10 to 15% in those that were treated with suvorexant. And then suvorexant also decreased the amount of beta amyloid in the CSF compared to placebo, starting about 5 hours after drug administration. So this is a small study. It's exciting to me and interesting to think about, is there, do these medications potentially have neuroprotective effects in regards to the development of neurodegeneration? Now, no talk of insomnia and insomnia treatment would be complete without mentioning cognitive behavioral therapy for insomnia, which works as well, if not better, than medications long term. This is, in our clinical practice guidelines, a number one recommendation. And basically, we don't just teach folks good sleep hygiene, but we also teach them things like stimulus control, or we might sleep restrict them. But basically, we help fabricate a mental toolbox for patients that they can use when they have some difficulty with sleeping. And we know, again, that this works quite well. Access to it can be a challenge, but nonetheless, there are 2 clinical trials ongoing right now to assess the impact of treating insomnia non-medicinally on aspects of dementing illness. So where does Alzheimer's disease really start? I think, this to me is a really interesting question. It used to be that we would look at clinical symptoms, look at mild cognitive impairment, and kind of say that's where it's starting. But as I mentioned, these CSF studies and these neuroimaging studies are giving us insights into preclinical biological alterations that indicate perhaps that somebody's walking a pathway to Alzheimer's disease or a neurodegenerative disease many years before symptoms would be expressed. And so, I think that we understand this is a dynamic disease, and that there might be some benefits to having preclinical diagnostic abilities in order to treat things like sleep problems, in order to possibly slow down or prevent the development of neurodegenerative diseases like Alzheimer's. This is this slide right here. I would say probably, if you're going to remember any slide from this morning, this would be it. Just kind of explaining this fear, this concern that insomnia medications are contributing to or causing Alzheimer's disease or other neurodegenerative diseases. And this is me. This is my sense looking at the literature right now. And of course, this could change. But my sense is that this is a distorted association between hypnotics and Alzheimer's disease. And what this is called confounding by indication. So this is a bias where an exposure and outcome are influenced by a third variable related to the indication for the exposure. So here, the third variable is the insomnia. I showed you earlier that insomnia can, all the different ways that data that we have that suggests that it can cause or contribute to the development of Alzheimer's disease. And we also know that insomnia would prompt a hypnotic prescription in some patients. And so, so this is going to result in this kind of distorted association that, hey, these sleeping pills, I heard these sleeping pills are causing Alzheimer's disease. Well, goodness gracious, don't treat me with that, whatever you do. And so I think that that's kind of what's happened here, and explains why you have that strange state of affairs that I touched on at the beginning of the talk, where providers don't want to prescribe medications they think work the best, and patients don't want to talk about it because they don't want to get a medication like that. And so if you look at, you have preclinical Alzheimer's pathophysiology, then you have insomnia and dementia and all those relationships, and that essentially the insomnia medication then would be at the scene of the crime, but not the perpetrator of the crime in this particular conceptualization of this issue. All right, so let's pivot here in the last third and talk about something called brain age and how this would fit in with what we're talking about. So you all may or may not be aware, but brain age is something that can be predicted by the electroencephalogram. And actually, previously, brain age was also able to be predicted by MRI. So neuroimaging studies of Alzheimer's, schizophrenia, epilepsy, traumatic brain injury, depression, all of these various disorders have been shown to be associated with excess brain age on MRI. And basically brain age is the difference between a measure that would indicate how old your brain is minus your chronological age. So brains can be older than the body, they can be younger than the body or the person. EEG is interesting because it reflects a more functional state of the brain than MRI. So this might be a better way to look at this than MRI. It's also ostensibly more accessible and potentially less costly. And as ambulatory EEG becomes more and more available, you might imagine that this could be something that could be measured multiple times in people that have an interest in it. So we did some research looking at this, developing a deep neural network model for brain age prediction and its association with patient health conditions. So we looked at people 18 to 85 years old. The training set was 126,000 overnight polysomnography studies or sleep studies. The validation set was over 6,000 PSG studies, and the test set was over 1,000 PSG studies. And the test set contained a number of these patient-reported outcomes here. Some are demographic, age, sex, You have BMI, you have measures from the sleep study. Apnea-hypopnea index is a measure of sleep apnea severity. Arousal index is a measure of sleep disturbance. Oxygen desaturation index is self-explanatory. Then you have sleep efficiency, which is the percentage of time that you're in bed trying to sleep, that you're actually asleep. And then sleepiness based on subjective reports in the Epworth Sleepiness Scale. You also have various diseases down here as well. And so what's going on with this model is, we have the nocturnal EEG from the polysomnogram, and we developed a deep convolutional neural network that was trained on these EEG and EOG channels. And so, what's happening is the model is generating a prediction of the age of the individual based on the raw signals, and then optimizes this error function such that the predicted age will match the chronological age as much as possible. So if we look here, if you plot brain age by chronological age, you can see that there are some individuals here whose brains are older than their chronological age, and then you have individuals over here where their brains are younger than their chronological age. So you see that the mean regression line, lines up with the y=x line, for the most part, but there is variability here. And then on the right, we see the brain age index distribution, which is fairly normally distributed. This is where, for me, I get excited. It's interesting. If you look at these specific diseases, so here we have depression on the left and diabetes in the middle and hypertension on the right. And those that have the disease or the positive group are in orange, and the negative group are in green. And you can see in every instance, the brain age index is higher in those with the disease than those without it, which would be as you would expect. We understand that depression and diabetes and hypertension are bad for brain health. And so that's what we see here when we look at this model. And here, just if you look at, those that have the diabetes, hypertension, diabetes, those people that have these things have positive brain age index, or the brain age is older than the chronological age. Those that don't have these diseases or issues don't have an elevated brain age index, and the p-value is significant here. So not just for these diseases, but also if you have a lower sleep efficiency, again, that's a percentage of time you're in bed that you're trying to sleep that you're actually asleep. That's associated with an older brain age. If you're sleepier, that's also associated. And if you have some memory and concentration issues, that is associated as well. And here, busy slide, but worth taking a little bit of time to go through. So each one of these panels represents a different person, okay? At the top is the hypnogram. So this is wake, REM, N1, N2, N3 sleep. And then you have hours at the bottom. So this is just kind of how sleep unfolds for this person throughout the course of the night. And then below is a spectrogram that's generated. And then on the diagonal here, you can see these are individuals where their brain age is younger than their chronological age. And, they have good, healthy hypnograms, and they have good spindle density that we see in the spectrogram. Here are people where their chronological ages and brain ages line up pretty well. And then here is the folks where their brain age is older than their chronological age. And you can see they have lots of wakefulness during the course of the night. And they don't have as robust sleep spindles. And then lastly here, when you look at, covariates that have significant correlations, all the things that would portend a good night's sleep, like how much N3 sleep you had, how high was the percentage of N3 sleep, how high was your sleep efficiency, how much sleep did you get, how much N2 sleep did you get. Those things were inversely correlated as expected with brain age. And then the things that would indicate a poorer night's sleep, respiratory disturbance index, which is a measure of sleep apnea, or N1 percentage, or wake time after sleep onset, are positively correlated with brain age. So we're seeing these things, we're seeing the relationships that we would expect to see between these measures and brain age index. So let me just kind of bring it all together here a little bit as we think about, what I've talked about this morning. So the pathophysiology of Alzheimer's likely unfolds over decades. But of course, there's no epidemiological studies and there's no randomized placebo-controlled clinical trials that are going to be done over that period of time to assess whether or not hypnotics cause dementia. Obviously, no IRB is going to prove that study. It'd be prohibitively expensive, and but you'd have a hard time enrolling anybody. But most studies assessing the relationship between hypnotics and Alzheimer's disease do not control for the presence of sleep disturbance. And I think the data showing that sleep disturbance is associated and contributing to the development of neurodegenerative disease is fairly strong. So that makes me a little bit concerned there. Again, I think looking at the literature in its totality seems to suggest that the insomnia medications are at the scene of the crime of Alzheimer's and other neurodegenerative diseases, but not necessarily the perpetrator. And then, with this notion of looking at preclinical Alzheimer's disease, the suvorexant study suggesting that there may be some improvements in aspects of the neurobiology of Alzheimer's in people that in that small study, there is an opportunity here, I think, as we understand this better, to improve sleep as early as possible in a person's life and potentially change whether or not they progress to develop one of these neurodegenerative diseases. And so with that, I thank you all very much for your attention. This is our evaluation QR code, so feel free to fill that out. I'd appreciate that. But yeah, I'm happy to take any questions. And again, really appreciate everybody's attention.
That was a great, thank you so much. And of course, I knew Mike Williams beat me to the punch. So Mike, you have a question for your fellow neurologist and professor of neurological surgery.
I do. Nate, I always learn from you. And I want to ask a question. As patients get older, we start to run into the problem that the benzodiazepines may exacerbate their ongoing cognitive disturbances. And so the question is, when do you become concerned enough to say that we need to find ways to come off benzodiazepines in order to treat sleep in the older population? And then the related issue, of course, is that the benzos have lots of other side effects in the older population. They increase risk of falling and so forth. What are your thoughts on that?
Yeah, thanks, Mike. I mean, it's interesting. I think that what's happened here too, and I didn't mention this before, is that a side effect of benzodiazepines can affect cognition, and that might be why people think that they can cause these diseases. We don't really use benzos per se that much in sleep medicine anymore. So a lot of these studies were done on medications. Were done at a time based on data sets for medications that we don't use as much anymore. We do use the Z drugs. And so that's something that we have in our armamentarium, and then also these DORAs, I think. So if I had somebody that came and saw me and they'd been on benzos long term, yeah, I would try to have a conversation with them about it, about their need for the medication, when did they start it, and have they tried other things, and kind of take it from there. The most commonly prescribed medication for insomnia in the United States is actually trazodone. And primary care loves it, even though there's very little data to suggest that it's effective. There have been very little studies looking at trazodone for insomnia, but be that as it may, that is the most frequently prescribed medication. So yeah, I think, Michael, if somebody came in on a benzo, we'd have a pretty long conversation, and I would endeavor to get him off of it for the reasons that you mentioned. Christoph?
Nate, thank you so much for the talk. I found it really intriguing. So I know this is not exactly our topic. I have two questions for you. Number one, the suvorexin works on the orexin receptor and is typically regulating wake mechanism. I don't know that much, but it's something that seems to be very instant in terms of mechanism of action. And so that is my number one question is, how quickly do you think these, like the sleep patterns affect, the metabolism? Is it more a chronic process, or is it more something that could instantaneously, affect this brain metabolism? In particular, because when I lived in Sweden, we had these white rooms, and people went there in the morning for 15 minutes for depression. And the question is that really maybe a small intervention is enough, or is it a chronic thing? And that leads to the second question. You didn't mention a single occupational study. With other words, is there, are night workers more affected? Are, neurosurgeons more affected? I missed it in your talk. So how do you bring those two things together? Thank you.
Yeah, I hope I can answer this. I mean, the orexin deficiency in narcolepsy, I mean, you have to wipe out like 95% of your cells or more before you're going to begin to express the disease. And so there's a lot of redundancy built into the system because of that. But you can think of orexin as, it stabilizes wakefulness and promotes wakefulness. And so, when we think about these DORAs, they're different than GABAergic sedative hypnotics. DORAs reduce the wakefulness signal. They don't sedate the brain. And that's been a problem because people have an expectation of kind of feeling sedated if they're going to take a sleeping pill. And they don't necessarily feel that way because, again, it's reducing the wakefulness signal. It's not causing sedation. So, that's the thing that we face trying to get patients to take these medications more long term. The shift work question is an interesting one. 20% of the population is a shift worker. There's no question that we're designed to sleep at night. I mean, Dr. Ellenbogen mentioned melatonin before, but melatonin is secreted by the pineal gland in the context of darkness. And so if we're sleeping during the day, we don't secrete as much melatonin. Melatonin has other effects. It's anti-inflammatory, it's anti-carcinogenic. It has many other effects in the human body. We know night shift workers, they're chronically sleep deprived typically, and they're at higher risk for a number of cancers, breast, colon cancer, in prostate cancer in particular. So anyway, I hope that answered your question. So Bernice.
Yeah, hi, thank you, Dr. Watson, for your presentation. I did have a question about, since you had your specialty in the Alzheimer's disease. Sometimes people who have the advanced disease of Alzheimer's tend to have issue with sleeping disorders, and that will probably contribute to their agitation and aggressiveness. How do you see that sort of the problem to be handled from like family perspective?
Yeah, I mean, we talked a lot about sleep, but of course, circadian health is crucial as well. You have to have both sleep and circadian health to have healthy sleep. And as we know, these areas, the brainstem areas that subserve control of sleep and wakefulness and circadian health, the suprachiasmatic nucleus in particular, can be impaired in people with Alzheimer's disease. And it can be a real challenge. There is nothing necessarily that is going to resolve it, but what we find is crucial is exposing these folks to light during the day and minimizing light exposure at night. Light is the single most important Zeitgeber, which is a German term called time giver, that entrains a human circadian rhythm way more than melatonin even, actually. And so this applies, I think, to those of us who take call, and particularly you all who have work schedules that can interfere with sleep. But yeah, I think so light's not the only time giver, though. When's your first interaction with another human being? When do you eat your meals? When do you exercise? Having rhythmicity to those things really does help entrain a circadian rhythm and can help people with Alzheimer's disease have maybe a little bit better of a sleep-wake situation, even though it's never going to be normal.